Morning, or sorry, good afternoon, and I want to let everyone know the meeting is being recorded. So I want to thank you all for joining the MHCC Health Equity Roundtable. My name is Melanie Cavalier, and I'm the Chief of Innovative Care Delivery at the Maryland Healthcare Commission. I'm joined by my colleagues David Sharp, Anena Anyabo, and Kelly Scott. In the event the meeting is breached, please hang up immediately. And then I will send participants an email with a new meeting link, and that will allow you to log back in. The recording will be available to the public. Please contact Kelly Scott or send a chat message if you're having technical issues. You should have received an email earlier today with her contact information. So at this time, I'm going to call the roll for participants and ask them to do a brief introduction that includes a few sentences about why you believe health equity is important. And I'd like to start with Dr. Zapp.
Hi, please call me Pat. I'll be brief because there's a lot of horsepower here on the phone and in front of us, and I don't want to use up a lot of time, but I was born into health inequity. As a child, I was exposed to a champion of health equity who really helped our community, which was so disadvantaged. And throughout my career in various roles, I had the privilege to help support advancement of health equity locally and at the state level and at the national level. So health equity is in my DNA. That's why I'm here.
Thank you so much for that. And I'm just going to kind of go across as the people are on my screen. Dr. Spots, would you like to go next?
Oh, thank you so much. I'm a newcomer to the group at the invitation yesterday of Pat, so really happy to join you, and please call me Doug. I'm a family doctor like Pat, and I would say again, this is born into my DNA. I came to Meritus Health in Hagerstown in 2018 after 22 of my 26 years up in central Pennsylvania practicing in independent family practice, and then getting into physician executive leadership with the community hospital there. Involved in a lot of the early ACO work with Geisinger and the Keystone ACO. I'm a past president of the Pennsylvania Academy of Family Physicians and a past president of the American Academy of Family Physicians Foundation. So I've also had the good fortune of being an early advocate as a family doc and working with some incredible leaders who have opened my eyes to all of the inequity and helping to overcome that in my community, and then on a larger scale through advocacy efforts in the state national academy. That's been everything from creating governance structures around diversity and really trying to, it really was my segue into population health more than an MPH or another advanced degree to really take on some of the challenges around health equity and moving some of those big boulders. That was pre-COVID. It certainly got accelerated during COVID and will continue for the rest of my professional career. Really happy to be with you.
Oh, well, thank you so much. We really value the input of all of you people who are doing this in your communities right now and have been doing it and letting us know kind of how that's changing and how, what efforts are going on. So thank you so much for that.
I should really just quickly add, sorry, that I started a family medicine residency here. So that was we got our initial accreditation in 2019, and we will graduate our first class, and we've matched every year since then. So creating that capacity, and I think that has been just a personal joy. And it certainly is a group that's tackling and going into the community to really help overcome inequity.
Well, that's great. And, we hear a lot about the lack of providers, especially in that area. So I think that's great that you've been able to increase that in that area. So thank you for those efforts. Dr. Khanna, you're the next person on my screen.
Hello to everybody, and happy Doctors Day. I've been working on health equity for a long time in various capacities. I think as part of the MMPP, we worked a lot on the Medicaid population that we had in our practices, and then ultimately wrote a very nice description of the fact that there were no differences in improvement in quality in Medicaid patients compared to others. And that sort of led us down a path to working with a lot of similar underserved patients in the PTN. And then I've been working on tobacco a lot, where we have been focusing on bringing services to those who are most underserved and live in geographically underserved communities. And then with the HRSA grant that I'm also working on with COVID vaccine access, all of our work has been in various types of inequities, underserved communities and such. So that's just a snapshot, but I do a lot of work in health equity and very happy to be here with other colleagues.
Well, thank you. You've contributed so much to the commission's efforts for so long, and we really appreciate your support of our different programs. So thank you for that. Angelica Newsom, you're the next person on my screen.
Hi, it's nice to meet everyone. My name is Angelica. I am a medical social worker. I have been doing this work actually since undergrad. Started my days working with refugees and asylees as a health advocate, and then started my career in the hospital with the Care Transformation Grants, and I was part of a new program for Sinai, then went to Absolute Care, and now I'm with Luminous Health. And so this work is just part of who I am. I truly believe in everyone being able to live out whatever their optimal health is for them. And so I have a full commitment to helping that happen.
Thank you so much. All your stories really, touch me. They're so inspirational. So you guys are doing so much great work out there. It's so great. Dr. Conway, you're the next person.
Thanks. Just want to unmute myself. So hi, Sarah Conway. Nice to meet everyone or see some of you again. So I am a physician at Hopkins. I'm internal medicine trained, and I trained here in East Baltimore and continue to practice as a hospitalist in East Baltimore. And I think that's where my perspective has really been grounded in seeing a patient population that is very much at need and requires lots of enhanced resources to do even some of the simplest things in terms of getting access to medications or to treatment, et cetera. So I think I grounded in that clinical experience, and then I've had a number of other sort of administrative roles over time that I think have given me some insight into how we tried to or started to try to really address health equity. So I've had a role in a lot of our value-based care efforts, our Medicare, ACO, our Maryland Primary Care Program, and now I'm the Chief Medical Officer for our Johns Hopkins Clinical Alliance, thinking about this and including these patient populations and trying to transform care. And then I've worn a number of different hats. I oversaw our sickle cell infusion clinic for some time, thinking about emergency access and immediate treatment for that patient population. I oversee our federally qualified health center collaborations as a health system, and have helped to transition one of our largest primary care clinics to an FQHC, sort of in collaboration with an academic medical center, so we can deliver sort of Hopkins quality care, but get all of the wraparound resources, and identified 10 different roles that we added to help support behavioral health, nutrition, and all those things to really sort of dig into how we think about care. And I also sit on the board of both one of our largest FQHCs and of our Priority Partners health plan. And so thinking about how we, from the payer side and the provider side, can really do things to transform access to care and add resources for patients. So I think it's from sort of beginning to end, from the clinical arena to how I spend my days, really thinking about how we do better as a broader system to make sure that access and quality are maintained for really critical patient populations.
It's great. I'm loving to hear too the scope of things that we're seeing and hearing, and getting that really diverse range there. So thank you so much for that. Dr. Jones, you're the next person.
Great, thank you. Thank you for the invitation. Pat, everybody that knows Pat Zapp knows that the reason why we're here is because we can't say no to Pat Zapp. So that's sort of why I'm here. But I'm Monica Jones. I am a system chair for Luminous Health, Women's and Children's Services. I have had a passion for health equity, particularly as it relates to outcomes for women and children, and the racial disparities that influence those outcomes. And so working in this space, I've had the wonderful opportunity to come into contact with people with a shared passion for it. And do believe that in order to improve the health of our communities, we have to reduce the disparities in outcomes, and need to engage partners in government, industry, health, communities, education, to really make that happen. So, so this is a part of my broader plan to engage every platform in the equity space and to really engage folks in this conversation. I too started a residency in OBGYN here at Anne Arundel Medical Center with similar goals to Dr. Spott's. Our program started in 2020. We take 4 residents a year. And they are committed every year to a community focused or community outreach project to raise their awareness around health inequities, and to really do their part in helping this. So so really glad to be a part of this group and looking forward to what we're able to share with each other and the state.
Well, thank you so much. And as you know, that aligns very well with some of the state priorities. Our goals that include maternal and child health is a very high priority for the state. So thank you for your work in that area. Melissa Zahn, you're the next person I have on.
Thank you. So I am Melissa Zahn. I am the Director of Integrative Health Services at Carroll Hospital. That includes lots of things, but mainly ambulatory care management, also known as health navigation, where I probably met most of you before, doing some care management work with you guys. But it also includes diabetes education, community education, and our Teva Center for Wellness and peer support program. So I've actually brought in Cheryl Gasagio because of her love of trying to help with health equity. So she'll be one of the people to introduce herself. And we've been working together for almost 9 years now on, taking care of people's barriers in the community. And Carroll County, only has us as an option, Carroll Hospital. So, it's tough sometimes to make sure that we are meeting the needs of all of the people in the community. And, Cheryl definitely has some experience in the past with some disparities, and her passion definitely will show.
Thank you, Melissa. And you're another person who's engaged with us for many, many years and many different efforts. And we do appreciate that continued engagement to help us support the practices. So thank you for that. Dr. Bazinski, you're the next person.
Well, thank you, Melanie. Sorry, I think I came on a little late, but I'm a family medicine doctor in Oakland, Maryland, way, heaven, almost West Virginia, way out here. And frankly, I've been inspired by the MD-PCP program and my opportunity to get involved with that. And I saw that it provided tangible improvements in quality for the target population, and to hear that, the MHCC is looking at healthcare disparities and looking at ways of, to me, I'm reading into it some practical ways of meeting these needs, other than me coming out to a rural underserved community, but some system changes that could really help, bring up those who have the least opportunity to be as healthy as they can be. It's in line with our mission here to help people have healthy, abundant lives. And I really came here to break down those barriers of this population, but to have the privilege and honor to sit at a table with people like everyone else here and have some small voice in the greater discussion is an honor. And I was frankly flattered that I got the invite. So I really appreciate the chance to contribute whatever I can, and really hope we can make some positive contributions across all Marylanders. So thank you again. I'm really, really honored to be here.
Oh, well, thank you so much for coming. And I just want to say, as a native West Virginian, I appreciate the needs that are, I grew up in a small town in West Virginia. So I appreciate the needs of the people who live in that area. I believe I mentioned earlier, but all of Western Maryland, while it's not large in population, the geography, when we show you the ADI map, you'll see that that is an area of large ADI need.
Oh my word, when I saw just to learn about ADI and then social determinants of health, you know, when you're out here in a small town and you're like on call, delivering babies, working at the hospital, like you don't get out much. Like it's hard to get downstate and go to great seminars and all that. And my connection through the MDPCP advisory committee, learning about those things, I'm like, oh, that's what I've always seen, that there's things way beyond just what medicines we give and what vital signs we get. I mean, it's that in my training, it was the biopsychosocial model of care, you know, encompassing all that a person is and all that impacts them. To hear that it's being defined, and once we can identify it and then start moving the needle, it's kind of exciting that it's not just me one-on-one with the patient making a difference, but people in this call are looking to make a difference across across all cultures, across all of our state, which is tremendously varied, but it's a bold goal, but you know, if any state could do it, Maryland could do it. So thank you again.
Well, and thank you again. And, you know, we do feel the MDPCP is a very important initiative, and we appreciate your support for the council as well. So thank you. The next person I have is Tim Wetson from, and I hope I'm saying your name right, from the Eastern Shore, so the other side of our state, which is also a high area of ADI. So would you like to introduce yourself?
Yes, good afternoon, everyone. Tim Wetstein with Atlantic General, Vice President of Practice Administration here on the Eastern Shore. Yes, we service Worcester County, which is about over 30 miles long, and we do see a lot of people who are challenged with our minority populations, and definitely health equity is important to us. I would like to say over the years, I've been here 4.5 years. The hospital started primary care home activities over a decade ago. We definitely joined into the Maryland Primary Care Program the first year it came out with 6 of our practices. So very pleased to be a part of that, and really a lot of growth. And we integrated care from the hospital into the health system several years ago. So on some of these things, when we joined Maryland Primary Care, we kind of felt like we weren't behind the power curve, you know, that happens sometimes, but we know there's always more to do, more to learn, and to help take care of our community. In addition to Maryland Primary Care, because we are bordered with Delaware, we get about 1/3 of our patients from southern Sussex County. So we also have a significant presence there. And I don't know how familiar you are with the Eastern Shore, but besides Ocean City, which brings a lot of people over here in the summertime, we also have a big agriculture community, in addition to a big poultry industry here on the Eastern Shore. So there's a lot of minorities that fall into that category of employment, and definitely want to ensure that we're doing things where we take care of everyone. And when we reach today where everyone has, you know, the equal access and equal ability to healthcare, then I think we will have reached a good place in healthcare. So glad to receive the invitation, as colleagues here on the phone have, and appreciate being a part of the group, and whatever part I can contribute, I'll be glad to. So thank you very much.
Yeah, so thank you so much. And we do appreciate having representatives from, again, all around the state to help give us those different perspectives, and even different communities in the same, you know, even different communities on the Eastern Shore may have their own uniquenesses. So thank you for joining us. The next person is Emily Gruber from the PMO.
Yes. Hi, everyone. My name is Emily Gruber. I am the Health Equity Program Manager at the Maryland Primary Care Program Management Office at the state. From my perspective, health equity is all about removing obstacles to health, you know, both structural and historical barriers from both within and outside of the healthcare system, and figuring out what's within our influence within the primary care level to make some of that change, and how we, from my perspective at the Maryland Primary Care Program, can kind of set up payments and programs to reduce disparities and focus on equity. So really happy to be here. Thank you for the invite, and happy to be with this group.
Yeah, so thank you so much. You guys are doing a lot of great work in this area and we appreciate the collaboration. So thank you for joining us today. The next person is Christian Gomes.
I'm Christian Gomes. I'm the director of Frederick Health's value-based care initiatives here in Frederick, Maryland. So I'll split the difference between the previous speakers in Western and Eastern Maryland. And I also, under that, lead our care transformation organization. And I'll say, I'll admit from the start that we're not perfect at what we do, but we have realized that our integrated care management teams are at least aware and sensitive to health disparities and inequities in our area. And I think I'm here maybe selfishly as an educational opportunity for myself and how we can help our providers in the community who are now challenged in the Maryland primary care program to make investments in themselves and their own practices to address some of those things. So I look forward to leveraging the expertise and experience of the folks on the call to understand how we might be able to coach and help our provider partners across Frederick County make an influence on their patients to address some of these things that we're all challenged with. So I look forward to learning, frankly.
Well, I mean, that's a big part of a roundtable. We absolutely want you guys to hear from each other and get ideas and things, takeaways that you think might work for your organization. So thank you for saying that. And thank you so much for being here. When you see the map, which we're going to pull up in just a couple minutes, you'll see that Frederick is also an area that is identified as a high ADI area. So I think the last person that I see is Cheryl, and I do not want to butcher your last name.
Sure. Hi, I'm Cheryl Gasagio. So I work at Carroll Hospital under Melissa Zahn. I supervise our peer recovery team as well as our ambulatory care management team. So I'm, new to this group and appreciate being included. I'm a social worker by trade. My background was in public child welfare before I came to start practicing in healthcare. So I'm just excited to kind of learn about what's happening throughout the state and what kind of initiatives are out there. We have a lot of community partnerships within Carroll County, so I'm excited to see how some of the statewide initiatives can be implemented and how we can leverage those community partnerships to really address the health equity issues that we have in our community.
Oh, yeah. Thank you so much for that, Cheryl. And I think you're actually going to be speaking about some of those community partnerships at a learning event that we have coming up in a couple months. So we're excited about that as well. Did I miss anyone on the call? I think I got everyone. Okay, great. So now I'm going to, and I just want to say thank you so much for all the work that everyone does in this area. It's just amazing when I hear you guys and everything that's being done to help the residents of Maryland. It's really moving. So I'll get on to more of the housekeeping items and into the meat of what we're going to do today. So there are a lot of people in the meeting and we would like to sequence speakers when possible. So if you could signal to the team that you'd like to speak by going to the reactions menu and raise your hand and then announce yourself when the facilitator calls on you, or alternatively, you can put something in the chat and we'll be monitoring that as well. So in the chat function, you can send messages to specific attendees or all attendees, or additionally, the meeting facilitator may call on people to ensure we have a range of perspectives. Participants may unmute themselves by using the small button at the bottom left of your screen. And at this time, I would like to ask David if he'd like to make any opening remarks.
Thanks, Melanie. Other than just applauding the great talent of individuals that are participating in this discussion today, not much more to add, but I think getting started talking about some of the challenges and opportunities for addressing concerns related to health equity is going to be a wonderful learning experience for all of us. There's a lot we can take away from as the Healthcare Commission in terms of what we can do as next steps to help inform broader communities of providers around the state. So you guys are sort of the genesis for really putting together some interesting ideas that can evolve to something bigger. So looking forward to hearing everyone's thoughts as we go forward this afternoon and through other meetings that will be scheduled. Melanie, please proceed.
Great. Thank you, David, for those kind words. The meetings of the roundtable, I'm just going to cover a couple of the items on the agenda. So all the meetings are going to be recorded and open to the public, and we do intend to hold them virtually. So we are hoping to have meetings monthly through July of this year. That will be driven some by the conversations and how long people want to continue contributing to the conversations. So the objective today is to convene a health equity practice roundtable with representatives from advanced primary care delivery practices to identify challenges and opportunities for practices seeking to address key health equity concerns in their communities. The roundtable discussions will inform the development of health equity resources for practices, such as an information brief or learning symposium. And this roundtable is just one of many state initiatives addressing health inequity. So I think this is a good point to mention this. The Health Equity Commission has a grant, and when we send you follow-up from this meeting, we'll just send a link to this grant. That's not our commission, it's a different commission, but I did want to bring it to people's attention for anyone who might be interested in applying for the grant. For the background on this and the rationale of why we're doing this today, and everybody on this call knows all these things, but reducing health disparities, which is defined as the difference in disease burden and health status between populations, is important to achieving Maryland's health system goals. Disparities can be identified based on race, ethnicity, gender, or rural urban geography, income, and other factors. So we're going to display a map that I've been talking about a little bit. This shows the Area Deprivation Index, or ADI, by census block for Maryland. So ADI is based on a measure created by the Health Resources and Services Administration, or HRSA, over 3 decades ago. It has since been refined, adapted, and validated to the census block group neighborhood level by Amy Kind and her research team at the University of Wisconsin. It allows for rankings of neighborhood by socioeconomic disadvantage. It includes factors for the theoretical domains of income, education, employment, and housing quality. And it can be used to inform health delivery and policy, especially for the most disadvantaged neighborhood groups. So I'm sure those of you on the call, as you can see, where we're talking about Western Maryland, not big population-wise, but big geography-wise. Frederick, I think you guys see that you're kind of that red spot over there on the left side. Most of the Eastern Shore is red. And then the area in Baltimore City as well. So we just wanted to share this with you guys. I don't know how many people have seen it prior to today, but I think it's interesting information for people to see. So with that, I'm going to turn the conversation over to Dr. Zapp to facilitate the discussion.
Great, and thanks everybody. I'm so impressed with the turnout that we have. It's wonderful to hear your stories. I do want to remind everybody, this is a roundtable, so I'm going to be calling you by your first name. Of course, you call me Pat as well. I'm also going to borrow some techniques from David Sharp, who is an expert in running these meetings. He's smiling. He's wondering, what am I going to say? Well, you have a great way of bringing everybody out, David, and everybody on this call is going to say something, whether they volunteer it or I point them out. So thank you for being such a great teacher. We're going to spend some time with this first meeting just doing some level setting to make sure we're using the same language, or if we're not, let's hear some new ideas. We have a very diverse group here. It's not just primary care, it's not just doctors. We have folks from different walks of life all interested in this topic. And I want to open up the discussion just to ask people, what is your elevator speech when you say, what is health equity? And we'll talk in a minute about what health equity looks like in the community when we're successful. So I am going to, if there's no volunteer, I'm going to go ahead and ask Sarah to give us her definition of health equity.
Oh, I was hoping there'd be a volunteer. So thanks. I was going to take a moment to try to get a nice pithy answer to that, which I haven't had a moment to do. But, I think when we think about equity, I'm thinking of the image that I don't know if you've ever seen where it's like 3 people trying to look over a fence and, there's the person on the box and the person who's on the ground. And Yes, there we go. Yes. Oh, yes. I forgot it was in the materials. And I gave a lecture to some med students on a health equity course and put this in there. And I think the goal is, when we're thinking about equity in healthcare, it's sort of an equal opportunity to really overall live a healthy and fulfilled life, right? And so that central box is I think capturing what that is. And we oftentimes think about it because we are very aware that we have communities that live in medically underserved areas. So it's a function of limited access to care and access to resources, but also to a variety of different, what I think we all call social determinants that fundamentally impact their ability to focus on or prioritize their health in the greater scheme of the life that they live. So health equity is focused on improving both access and quality of care, but I think also allowing everyone to come to an equal level to be able to even think about and address their health care. So sorry, that's one of those times where I was just saying things as I was actively thinking of them. So hopefully I came across in a coherent fashion.
Yes, you did. And it's hard to do an elevator speech. I get it completely. And, you know, we wonder what health equity is. And the definition of that is it's probably very person dependent, right? Angelica, how would you how would you define it?
So of course, when I think of health equity, that same picture comes to my head, but I also think about the number of conversations that I've had with individuals when they find out I'm a social worker. They like to pick my brain. So someone will say, and it's actually one of my friend's fathers, you know, well, I overcame my alcoholism and I got a job and I did this and I did that and I came from nothing and look at me. So why can't everyone else just do that? And to me, what he's pointing at is this idea that resilience somehow cancels out us having to do any of this work, that it's an individual failure if you're not reaching your whatever society is saying is that reachable or attainable goal. And so when I think about doing health equity work, it's saying that I don't think that a person has to be resilient. I want to make a community and a system that allows for you to get the need that you need as an individual, rather than putting everything on you. So for him, the fact that he, you know, did the American thing and pulled himself up by the bootstraps is wonderful. But for that person that actually needs a little bit more hand holding through the system, that needs me to help coach them through how to have conversations with providers or where they can get this resource or that resource in order for them to reach the same success as him, there's no shame in that either. And so I think that's the journey to health equity too.
Great. I like the way that you put it, that resilience does not equal self-worth, or I might be putting words in your mouth. It's recognizing that some people will need help to get access to what the rest of us have been born with a right to have, right? And I think you're kind of like hitting the issue of social injustice as well as institutional racism, that we have to bear in mind that many of us are walking around with privileges. So I want to ask Ken, when you're thinking about health equity in the exam room, what does that look like? What comes to mind to you when you're thinking about your patient in front of you?
Oh, good question. Thanks. You know, I've been wrestling with this ever since I accepted the invite of, you know, what would I say health equity is? And, you know, to me, we ran into the patient autonomy issues out here during COVID, which I literally in the hospitals taking care of people dying, and they had no regrets of COVID, and they had no regrets for not getting the vaccine. And I'm just like, wow, that's amazing what we'll do to ourselves just so we can express our autonomy. And it sounded like foolishness to me. Here's a vaccine that could save your life and keep you alive to see your children and grandchildren. You refused it. You know, they had access to it, they refused it. So, you know, I think health equity to me is, you know, allowing equal opportunity for each individual to be as healthy as they want to be. Because if we start saying health equity is everybody getting the vaccine, we have just crushed autonomy. And I've seen some people who are very sick and very unhealthy, and they would rather live alone in their house and die on their terms than live longer in a nursing home. So it's really hard for me to think what really is the optimal, because I love that graphic of the ball game, people watching a ball game. But I was like, I've got some patients, they don't even want to go to the ball game. They're like, you can give me box seats and I'm not going to show up. So somewhere in here, to me, there's this patient autonomy thing that I think society got a slap in the face about, but which those of us in the exam room or in the patient room talking to them about their healthcare choices, we've long wrestled against. There's ways that you could be healthier. There's things you could do where you could be better. We know controlling your diabetes will let you be healthier and do more. But to them, they're like, I don't want to be inconvenienced by taking a shot or taking a medicine. And education is part of that. Culture is part of that. But some of those is just, I don't know. To me, it's giving everybody the opportunity to access services, to bring them to the best of their ability, to the healthiest you that they want to be. But I feel it just, well, I mean, part of it's emotional. I've seen people I've cared about who've chosen things that have led to their untimely death, and it's been really magnified in the last 2 years. But yeah, that's, I think for people to be whole and to have peace about their decisions, they have to have some sense of autonomy in this, because the more we push it, maybe I'm in this, skeptical Appalachian culture who anything that somebody from the outside is telling me to do must be wrong until proven otherwise. And so, to me, it's just a matter of giving people the opportunity. And as I tell my patients, I'm like, you could treat your diabetes, you could try to treat your cholesterol. And if you don't, I'll be here when it all falls apart and I'll take care of you then. Mm-hmm. And yeah, that's my thoughts. Thanks for asking.
Yeah, and Doug, we'll get to you in just a second. I think that autonomy issue is so important. People can define health in their own way, right? We don't define it for them.
Yeah.
And, in studying for this meeting, I looked around at different organizations' definitions of health equity. And the CDC, I think, might strike a chord with you, which is health equity is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. I think that, that the way that they worded that includes that autonomy piece. Doug, what did you want to say?
So piggybacking on this great discussion from a primary care lens, I love that, and it sort of encapsulated where I was going to go, Pat, but it was really everyone has equal opportunity to quality, I would say, wellness, prevention, health, and healthcare, regardless of socioeconomic or other racial, ethnic barriers, challenges. And it gets a little bit at full potential. We've been doing some work at Meritus around what matters most and asking that simple question, capturing that for every one of our patients. So I love what all of you have just said, what Sarah typed in the chat, what Ken talked about, Pat, when you said, what does health equity look like in the exam room? And another part of health equity is, what about those people who can't even get to my exam room? How do I get to them? And it also gets to that question of what matters most to them. They may not even want to go to the ball game. And the other common visual that sort of gets at equality, equity that I like, because I'm a visual learner, is the one where equality is everyone gets a bicycle. But equity is, it may be a tricycle or a seated bike or a child's bike or a bicycle, for an adult, and everybody gets what they need to get to more of the equity and the justice. And it is a little bit of that same, where do we meet the patient on that journey? Mm-hmm. Thanks.
Thank you. And I have a confession to make. Somebody tried to call me during this meeting, so I've lost the screen view. I have your pictures, so if you're raising your hand, I might miss you, so I'll ask the staff to help me out there. I did want to move on to the next question, which is, well, okay, let's say that we achieve health equity. What does that look like? And Tim, I want to ask you a specific question, because where you are, you have different populations. You have folks who have to do a lot of work outside, for example. You have probably a population that's incredibly vulnerable to, say, climate change, right? And health equity is tied up with climate change, and climate change, like the pandemic, exposed a lot of health inequities. When you think about your own community, Tim, in achieving health equity, you could wave a wand. What would that look like for the people that live in your region?
Oh, there's two things really that come into play being on the Eastern Shore. We also have a nickname. It's called the Gray Shore. And the reason why I say that is we have a high Medicare population. When we look at our payer class mix and hospital admits and all that, over 50% of all the patients we touch are Medicare on average. What has happened when we think about climate and tying into health equity and all, who you would expect to come to the hospital and get care came to the hospital. What I mean by that specifically are senior citizens, Medicare patients, the Caucasian population. We did see and we experienced from things that have happened over the years, our African-American population here was hesitant to seek vaccines. They were hesitant to take care of their health needs because of things that happened, through the government and things that have happened over the years. So it was a challenge. Fortunately, we have a diverse healthcare workforce here. So, and actually our pharmacy director, who's a wonderful African-American gentleman, actually went to several local churches and all and reached out to them and to break down the barriers, because there's a problem when people feel like they're not going to get the same type of care. And you would think in the 21st century, we would be past that, but unfortunately we're not. And then the other thing in our local community, especially our southern Delaware portion, again, 1/3 of our patients come there, the Hispanic population and things that have happened with immigration over the past several years, they will also delay their care because of the stigma of, am I a legal citizen, or I'm going to be treated like someone who's an illegal alien or whatever. And that's a challenge, because we want everyone, we great definitions and great communication regarding what health equity is. And I go back to my initial comment is when we get to a point where everyone has equal access to equal care and everything is available to everyone, then we've reached the summit. That's where we need to be. But unfortunately, depending on what ethnicity you may be and things that have happened in the past and all, people stop short of getting the health care that they should get. I mean, we know when COVID first came out, it was so unknown. There were so many things that there was a lot of misinformation that was out. So, I mean, really, our numbers in the hospital significantly dropped off because really people believed if you go to the hospital, you're going to die. And that was really sad that people embraced that and believed it. And that was the furthest thing from the truth. Quite frankly, we already were, pardon the expression, but it's true, a clean hospital. But our environmental services team stepped it up even more. I mean, they were cleaning areas I've never seen cleaned in a hospital before. I'm like, what is this? But of course, it was the benefit for everyone. And we were able to tout as one of the things is we had no employee to patient COVID transmissions because of our environment was so clean. But the bottom line was stigma, things that happened historically, depending on what ethnicity you were, retarded people's from getting into and getting the care that they needed. So I think we've We've come a long way over the last 2 years. We look at our statistics. We also are internally tracking, our ethnicity and the different classes and groups of people to see that are the numbers getting back to normal, or is there still disparity? And we're seeing numbers return back to pre-COVID. We're seeing people get the care that they need. So I think we've been able to move past a lot, but it was sad that people did not get to where they needed to go, and meaning the care they need to get because of misinformation or things that happened historically. But I think we're better in 2022 than we were in the spring and summer of 2020.
Good.
So Dr. Zapp, I think we have two people with their hands raised. I believe Dr. Jones was the
Yeah.
first one, and then Cheryl.
Monica, I'm glad I was going to call on you next, but please go.
Yeah, I try to beat you to that, right? So I didn't get a chance to see who was speaking last, but he is spot on around the fear that some of our vulnerable populations have of the this existing healthcare structure that is an incredible barrier to them, to equity and care. And so what I would like to see us do is I would like to see us leverage and partner with what communities, what individuals decide is the source of truth. Who's your source of truth? It could be your church. It could be your community center. It could be your family. But we have to partner with individuals' sources of truth, help them overcome the barriers and suspicions that come with healthcare and our desire to see a healthier population, and overcome those using those partners. I think the other point that I wanted to make was that patients now want to get the care that they need and want on their terms. So that is going to require that we get over ourselves, get beyond ourselves to really understand what are those terms that patients want to receive care. And then finally, one of the other speakers was just talking about defining health for an individual. It is different for everyone. It is going to mean asking folks to understand what each patient's view of health is, and how that contributes to their wholeness, psychologically, mentally, physically, et cetera, to be what they want to be in society. So I think that's critically important as well. So thank you. I apologize for taking that much time. So much, was spurred by what other comments that were made. So thank you.
That's fantastic. I think Cheryl's next.
Yeah, just wanted to add on a little bit. I think what I'm hearing folks saying that I absolutely agree with is that to see health equity be achieved in communities, there really needs to be work on both macro and micro levels, that there are systems in place that are, in themselves creating barriers to health equity, but there are also going to be individuals that are experiencing, things on that individual level that are preventing them from being able to have individual access to equitable care. And so addressing those system barriers, but also putting practices into place like trauma-informed care so that clinicians or whoever is coming into contact with those patients in the community are able to identify the individual factors that are playing into health equity concerns as well.
Absolutely. Thank you, Cheryl. And Emily, you wanted to add?
Yes, I think one piece I'll add here is that, access to care is often hindered by cost. And in this, when we are successful in achieving health equity, kind of dream, if patients didn't have cost barriers to accessing care, and potentially that includes insurance barriers as well. I think that's a key to aim for. And I will also emphasize the partnerships piece as well. I think it's also important to recognize that not all of this change comes from healthcare.
Right.
What are the root causes of poverty and inequality? And often, both at the macro and micro level, as some others were saying, this change is both within healthcare and not in healthcare very much so. And I think the partnerships are really the key to making sure that these are systems changes, not only in the healthcare system.
Thanks for calling that out, Emily. And Sarah, let's hear what Sarah has to say. And then quickly, I want to pivot to one last question because I got a couple other people who haven't spoken yet.
Yeah, I'll keep it very quick. I think the comment was made before about different patient populations and their backgrounds. To me, health equity would look like a healthcare workforce, and that workforce broadly defined being one that more mirrors the patient populations that are served. And that can be in a variety of different ways. I think that can be sort of the racial or gender mix. It can be language. It can be gender identity. It can be other things, so that there is a better ability to understand the patients and their experiences and their priorities and all of those things that have just been mentioned, and their challenges as it relates to their healthcare. So I think it was Ken who wrote, he moved to a new community and you have to get trust and buy-in, and then he became a resident of that community and so understood in a new way what it meant to be there. I think in the same way, there are certain things you can't just move into and experience. And so having a healthcare workforce that's reflective of the patients and the community, I think is very powerful.
Cultural humility. I hear you. Is Naharka still on? I can't tell. Doesn't look like it. No? No? Okay.
No, she sent Pat, she sent a chat early on. She had to leave early.
Oh, okay. Well, I'd like to ask Christian, since Christian's working with providers. Christian, if you're still there, I think. When you're having the discussion with providers and they're trying to balance all their various priorities and they're on all these programs. This is a loaded question because the question has the answer. What is the business proposition that you offer them when they're on the fence about, well, is health equity a priority for my practice or not? How does health equity and trying to achieve health equity help the provider?
I don't think Christian is on the call. Sorry.
Okay. All right. Melissa, do you want to take that question?
I think Melissa had to drop off as well. Cheryl works with Melissa. Melissa sent me a message as well.
Okay. All right.
Hey, Pat.
Yes.
This is Ken. If you don't mind, I'd love to say something about this.
Please.
Yeah, this is amazing. You get what you pay for, really, and I don't know if anybody remembers back to the late or mid 90s, MCOs, managed care organizations were taking off, and doctors were given a panel of money to care for their panel of patients without any risk assessment or anything. And so I heard of doctors moving their offices to second-story buildings with no elevator.
Right.
Because then they have healthier patients who spend less money and they get more for themselves. So, I mean, human beings are intrinsically looking out for ourselves and our best interest as however we define them. And I was, again, encouraged by MDPCP, how I was able to shift the needle and move what we do in the exam room and in the practice and policies within the practice. I have a small for-profit practice with like 10 providers. And so what gets paid gets done. And I don't know how to do this or how to, provide this motivation, but I really appreciate this group looking at this because, in primary care is sort of the catch-all of, oh, and you need to do this, and you need to screen for this. And don't forget to, every health issue is a primary care issue. So our scope of practice is nothing yet everything. So, if this is something that society and culture matters, it needs to matter to people who pay for healthcare. It needs to matter for people who deliver healthcare. It has to matter to people who are getting healthcare. And I think whether people realize it or not, it does matter to those who are getting healthcare. And I would love to find a way that's, again, not horribly coercive, but I think if you get back to most of us, at least the physician level, who go into healthcare, especially in primary care, we have some ideals and principles that drive us to do what we do. And we all continue to practice in one of the poorest paid medical specialties because it's intrinsically valuable and motivating. And those relationships work both ways. Our relationship with patients help them buy into our recommendations of care. And those relationships with patients motivate me to continue showing up and working, even if it's, there's a lot of negatives behind it. So I appreciate this. I'm not quite sure what the business proposition is, but many of us get into healthcare because we want to close those gaps. We want to see those who are suffering the most, achieve health and, personal homeostasis. So, yeah, thanks. Thank you for asking the question. I just appreciate that.
And it looks like two of our colleagues have some ideas, and if I could ask them, I want to be respectful of time. I do want to hear what you have to say. We all want to hear what you have to say. Let's try to wrap it up with both Angelica and then Doug.
I just wanted to say, I think the buy-in is, as providers, you are in the business of helping others. And so to really take a holistic approach to that person, you can prescribe diabetes medicine all day long, but if the person's food insecure or they don't have the transportation to come and see you the way that they need to, then you're not going to get the results that you're looking for and seeing that improvement when you can help. So it's the buy-in of, this is really how you see long-term results. This is how you win the long game with patients. So
thank you. And Doug, are you still there?
Yes, I am. I'll try to be brief. So I think that attempt, by no means not the exact answer for a business proposition, is funding for advanced primary care teams. So we have licensed clinical social workers on here, embedded behavioralists, embedded pharmacists, collaboration. I think we have a uniqueness in Maryland around the MD-PCP program and becoming a CTO to do a little bit of this, but really whether that payment comes from the insurers or from decreasing the penalties that of our total cost of care system from QBR, there's a uniqueness in Maryland that I think we've started on, but I think we could capitalize on to really fund foundational primary care advanced performing teams. And hopefully the dividends would pay off to do a bit of what Ken started us on. And then, I think, well, I'll stop there. I think that sort of summarizes an attempt at what we could maybe do. We do have to get away from rewarding interventions, and I'll say the nasty term, RVU, not that productivity is going to go away, but a system based on interventions and things we do, which many times we know as clinicians are not only not helpful, they're actually harmful. And so I think that's a shift that we need to work for.
Absolutely. And thank you for that, Doug. So great discussion. And now our future meetings will have more time to talk, we promise. So don't worry about that. I'll close by saying this just came across my desk today, a survey done of multiple different types of physicians. Only 1/3 were primary care, but the vast majority did recognize, as Angelica said, I can't move on my quality metrics until I address this other big elephant in the room here. By the way, how do I do that? I want to. So how do I do that? And I think that's part of what we're trying to figure out together in subsequent meetings. I will turn the meeting back to the staff at this point, and I wanted to thank you personally. It was a blast listening to you, and it's great to be around folks who are so passionate about health equity.
So I just want to again, thank you so much, Dr. Zapp, for facilitating this conversation, but thank you to everyone on this call, because I really feel that we've heard so many wonderful ideas and things today that can really guide us. And it's just really great to hear all this conversation about this topic and how we can potentially move things in areas where we should be looking at to maybe for some solutions. And so there will be a recording of this meeting and a summary posted to the MHCC website, and we are planning to schedule a meeting for May. So at this time, I just want to turn it back to David to see if he'd like to make any closing remarks.
So thank you, Melanie, and a huge round of applause to all the participants in this discussion this afternoon. I think we're off to a good start. I think there's a lot of commonality in what you all believe to be the challenges, and I hear bits and pieces of solutions even that you have in mind. And I think that future discussions will dig deeper into them. And I hope we've teased you all enough that you'll come back for the other conversations. And I think Dr. Zappi did a great job facilitating the meeting. So much appreciated. And to all those folks that we didn't get a chance to say hello to personally on the call today, we're enormously grateful for your time and your contribution to the cause. So thank you all. Have a great afternoon, and we absolutely look forward to more conversation here. Melanie.
Thanks, everyone.